In this presentation, we will be discussing tears of the superior labrum from anterior to posterior, aka SLAP tears. We will be discussing a brief review of anatomy, presentation, clinical examination, mechanism, imaging, classification, as well as management options. The labrum is a triangular fibrocartilage structure that is an extension of the glenohumeral ligaments. It surrounds the glenoid and acts to deepen the socket, increasing the head contact area and increasing joint stabilization. The biceps tendon inserts to both the capsule and the labrum at its insertion on the supraglenoid tubercle. The blood supply to the labrum is via the suprascapular artery, posterior circumflex artery, and the circumflex branch of the subscapular artery. The porous blood supply is to the anterior superior labrum. For descriptive purposes, labral position is localized by superimposing the face of a clock onto the surface of the glenoid. By convention, the 3 o'clock is anterior, 9 o'clock is posterior, 12 o'clock superior, and 6 o'clock is inferior. Alternatively, you can divide the labrum into 6 segments: superior, anterior superior, anterior inferior, inferior, posterior inferior, and posterior superior. Pain is described as a deep anterior shoulder pain, often with clicking during overhead activities. Often the patient's primary concern may be of weakness and decreased athletic performance. Pain can present acutely after trauma, such as with a fall on an outstretched hand injury, or chronically with repetitive use, most commonly seen in laborers doing overhead work. During examination, the patient may have pain with palpation of the long head of the biceps tendon. The strength testing is frequently normal, as is range of motion. However, some patients may present with GERD, and it is therefore important to assess their external to internal rotation arcs. The provocation tests to consider including are the O'Brien's test, with forward flexion of the arm to 90, with the elbow extended and the arm adducted 10 degrees. The patient resists the examiner's downward force on the arm, first with the arm internally rotated so that the thumb points downward, and then the arm is fully externally rotated and supinated. Pain present in the first position that is relieved with supination is considered a positive test. The crank test is where the upper arm is internally and externally rotated while the arm is maximally elevated in the scapular plane with an axial load to the glenohumeral joint. The dynamic labral shear test is where the elbow is flexed to 90 degrees and the arm is abducted to 120 degrees while maximally externally rotating the arm. The test is positive if there is pain from 120 degrees down to 90 degrees of abduction as the arm is lowered. It is important to note that none of the provocation tests have reliable sensitivity or specificity. Apprehension testing is often positive. The most widely accepted mechanism by which SLAP tears occur is via the peel-back theory. Here, abduction and external rotation of the shoulder causes the biceps tendon to assume a more vertically oriented position, thus transmitting force to the superior labrum, causing it to peel off the glenoid. Imaging of the shoulder for assessment of SLAP tears may include radiographs to rule out other pathology since they will likely be normal in the context of SLAP tears. MRIs are frequently used to assess the labrum for pathology. The labrum is a low signal structure on MRI, and therefore the primary MRI finding on T2 weighted images is a linear signal intensity within the superior labrum. Other features of pathology are lateral orientation of high signal intensity on oblique coronal images, irregular margins, increased depth of separation from the glenoid greater than 2 millimeters, and extension posterior to the biceps tendon. A perilabral cyst can often be associated with the SLAP tear, and when seen on MRI, it's often indicative of SLAP pathology and may be the first sign on MRI. The only true diagnostic test, however, is direct visualization with arthroscopy. The most widely used classification for SLAP tears is the Snyder classification. There are 4 described types. Type 1 is fraying of the superior labrum with an intact biceps tendon anchor. Type 2 is fraying of the superior labrum with detachment of the biceps anchor. Type 3 is a bucket handle tear of the superior labrum with intact biceps tendon. Lastly, type 4 is a bucket handle tear of the superior labrum with extension into the biceps tendon. However, part of the tendon anchor may still be intact. Conservative management for SLAP tears includes NSAIDs, activity modification, and physiotherapy, but it is generally unsuccessful. Surgical management is frequently undertaken via arthroscopy. The goal of surgery is to reattach the biceps tendon. The Snyder classification is useful insofar as it helps guide management. Type 1 tears tend to be managed with debridement alone. Type 2 tears require the addition of tendon repair. Type 3 and 4s require the bucket handle tears be resected. Type 4 necessitates that the biceps tendon be addressed. Typically, if less than 30% of the tendon is damaged, it can be left intact. If more than 30% is affected, it should be reattached in a young active patient in comparison to tenodesis in the older patients. Thank you for listening.